All right, this is going to be your chapter 17, loss, grief, and dying. Your learning outcomes that can be found in the book are key terms, which are also going to be discussed on this slide and found in the book. So when we start, we want to say what's loss, right? And this is the undesired change or removal of a valued object, person, or situation. We can categorize lost, right? So an actual loss includes the death of a loved one or a relationship, theft, deterioration, destruction, natural disaster. Loss can be identified by others, not just by the person experiencing it. We can have a physical loss, which can include injuries like the loss of a limb or amputation, organ removal, such as a hysterectomy, loss of function like paralysis. We can have a psychological internal loss. This is commonly seen in areas of sexuality, control, fairness, meaning, and trust, loss of youth, body disfigurement. We can have an external loss, which are actual losses of objects with sentimental or monetary value, like jewelry or home. We can have environmental loss, which involves the change in a familiar environment, even if the change is perceived. So a good example of an environmental loss would be moving to a new home, getting to a new job, losing a job, going to college. Loss of a significant relationship could be the loss of a spouse, a sibling, a family member, a significant other. When we talk about a tangible loss is something that we have that's actual, something that's actually gone, versus a non-tangible, which is a perceived loss. So perceived loss is internal. It's identified only by the person experiencing it. So if I had in my head that I was going to be married to a wealthy person, right? I have the actual relationship and I'm going to marry them and I'm going to be wealthy. I'm going to have this lavish lifestyle. And then we break up and I'm more upset about the loss of that lifestyle that I was going to have. That would be a perceived loss. If I'm more upset about the person I lost, that would be a tangible, actual loss. So a perceived loss, it was never there to begin with. So this is the example that we had in class, and it's the perceived loss, right? Because they never actually had the career as a nurse. So with loss, we have grief. Whenever there's a significant loss, there has to be a grieving process. Grieving requires energy and it can interfere with our health and delay healing. It is positive and essential to the psychological healing after a loss. Grief is the physical, psychological, and spiritual response to loss. We have mourning, which consists of actions associated with grief. Sometimes we might have wailing, we might wear black clothing. These processes are normal and they're a natural response to loss. Bereavement is the period of mourning and adjustment after loss. So there's many theories about your foundations of grief. You can refer to table 17-1 in your textbooks. All of these theories start with the basic disbelief, right? It may be called that you're going to be going into shock, maybe denial, it may be even numbness, but the idea is all the same, that we just cannot believe that the loss has occurred. When we talk about the different ones, Engel believed that uncomplicated grief has a clear onset and a predictable course. It's modified mainly by the abruptness and the significance of loss and the preparedness of the bereaved person. Uncomplicated grief is universal and does not require treatment. Globally, this is a drawing on an attachment theory. It suggested that grief occurs when the bereaved learn that the object of their attachment is loss. RANDO stands for recognizing the loss, awareness, reacting to the separation, so you're feeling the emotion, recollecting memories of the deceased, so remembering, reliving. You're going to be relinquishing the old attachment, so new ways of living without the deceased. We're going to be readjusting to the new environment, so it's going to be new coping skills. We're going to be reinvesting ourselves. Energy once turned inward on grief begins to be focused outward again, and that's what random is. Worden describes the task a grieving person must achieve. They progress from the initial numbness of the denial through experiencing it and working through pain and grief, and eventually moving on with life. Kubler-Ross has 5 stages of grieving. Individuals may not experience every stage or go through the stages in a linear order. In addition, individuals may experience 2 or more stages simultaneously. Strobe and Schuch is a dual process model. Mourning is cyclical. People oscillate between 2 dimensions in bereavement. Nickelman et al. Bereavement or grief is never fully resolved. The focus should not be on individuals obtaining closure, but a way to find new ways to relate to decreased. The griever maintains continuing bond with the deceased. And our final one, grief is a process of meaning reconstruction. The best predictor of a positive adaptation to loss is the ability to find meaning in the loss. The unsuccessful struggle to find meaning can result in complicated forms of grief. So what's going to affect our ability to grieve? So the significance of the loss, right? How much did the person that's grieving attach to this project, person, or object that's been lost? If the attachment is more significant, it's going to be harder to grieve. The support system. If the person who's grieving has a lot of support, it's going to be less complicated than somebody who has less emotional support. If we have unresolved conflict prior to the loss, so if conflict exists at the time of death, conflict left unresolved may cause a prolonged grief. So if you got in an argument with somebody right before they died, you could have unresolved conflict complicate your grief. Circumstances of loss. So if the circumstances of the loss leave the bereaved person feeling guilty or responsible, his or her healing process may be impeded. Previous loss. If a person has sustained more than one loss in a short period of time, the grieving process can become more complicated. If the person has had prior loss, they also could be less complicated if they've developed the coping skills from the previous loss. So that could work in either way. Our spiritual cultural beliefs and practices. Spirituality and religious beliefs can help or hinder the grieving process. Most cultures encourage rituals that help the bereaved begin the grieving process by openly expressing their emotions and pain. Some cultures, though, may emphasize keeping emotions more subdued and limiting expressions of the grief in a private setting. The timeliness of the death. The death of a child or a young person is almost universally more difficult to accept than the death of an older person. In addition to loss of a person, there is also a sense of unfairness because the loss of the potential of what might that child or that person have achieved. You may hear someone ask, why was their life cut short, or state he had so much going for him, but God didn't give him a chance. As we age, our families age, we can accept that some elder will pass. Therefore, the context would be different and difficult if it was somebody young who passes. Our developmental stages can affect our bereavement, and we're going to talk about that on the next slide. So children have a very hard time with understanding that death is permanent. A lot of times they think that it's reversible, kind of like cartoon characters, and they'll wonder when the life is going to come back again. An adolescent is already struggling to learn who they are, and they start to break away from their parental control. The loss of a parent while pushing the parent away can create a sense of guilt and unfinished business. At the same time, the bereaved teen also faces physiological, psychological, social, and academic pressures. Although teens may look mature, they often lack emotional maturity, but are often expected to grow up and support a surviving parent or younger sibling. When they feel this responsibility, they do not have the opportunity or the permission to mourn and may turn to those outside of their family to discuss their actual feelings. Adulthood. Adults are cognitively able to understand the nature of death and have usually experienced other types of loss. Over time, they perceive loss as a normal part of life. However, they respond to loss depends on factors such as their personal self-esteem and the support that they might have of others. Older adults, a special difficulty for older adults is the cumulative effects of many losses that they experience. Most death occurs among older adults, so they are likely to have lost friends, siblings, in rapid succession, in addition to physical and functional losses and loss of independence. In addition, they begin the process of preparatory grief in anticipation for their own death. The emotional effects can be devastating. Research has revealed that elder adults who have suffered the loss of children experience significant and sometimes irreparable mental and physical outcomes, accelerated disabilities, and loss of the ability to function independently. To minimize these negative outcomes, caregivers should use listening skills, metaphors, and promote storytelling. So our types of grief that we can have uncomplicated grief, and this is the normal grief. It's a natural response to loss. The bereaved person experiences feelings, behaviors, and conditions that are expected in light of their cultural, social status, relationships to the lost person or object. The emotions are intense but gradually diminish over time. This may take several months to several years. Some emotions will be present, but the intensity will change. Then we go into our dysfunctional or complicated grief. It's distinguished from uncomplicated grief by the length of time and the intensity of the emotions. The person's responses are maladaptive, they're dysfunctional, they're usually prolonged, and they're overwhelming. Complicated grief results when the grieving process has been impeded for some reason. Something has kept the person stuck in the grief process. So we have chronic, which begins as a normal grief but continues long-term with little resolution of feelings and inability to rejoin normal life. We have masked. Mask occurs when the person is grieving but expressing the grief through other types of behavior. So drinking alcohol excessively to mask the pain of their loss. Delayed. Delayed is grief that's put off until later. I'll think about it later. Right now, I'm trying to keep a roof over our heads and care for my children, right? And then we have disenfranchised grief. So this is expressed in connection with the loss that's not socially supported. or acknowledged by using rites or ceremonies. Disenfranchised grief may be experienced by the unplanned termination of a foster child placement or mistress who lost their lover. Right, neither one of these you're allowed to actually go out and grieve the way that you would like to. In these instances, the bereaved person lacks the communal support that's helpful in grieving. Anticipatory grief, this is grief that's experienced before the loss occurs. It potentially has a negative outcome for the anticipatory grief, and the survivor might actually start to detach from the dying person too early in the dying process, leaving the person without emotional support during that period. This does not always happen, but it's possible. And this is masked. I know my boomerang went low, but that was the answer for that, is masked. So how is death defined, right? Higher brain death means the brain stem can still function, so you still have respiratory and cardiac activity. And it may continue even though the person is not made purposeful, responsible to external stimuli. Reflexes are absent, and we have no activity on our EEG. There is a Uniform Law Commission which redefined death broadly as irreversible cessation of all functioning in the brain, including the brainstem, as determined by reasonable medical standards. This definition did not provide clear guidance to states. So the Uniform Determination of Death Act was adopted in 1981 to further clarify and expanded the previous definition to include the irreversible cessation of circulatory and respiratory functions based on acceptable medical standards. Providers use several methods to assess for functioning brainstem, such as pupils that are unresponsive to light, no corneal reflex, and absences of other reflexes. We have a patient who's in a coma, and a coma is going to be a prolonged, deep state of unconsciousness. It can last for days or even years. The patient cannot be aroused, but they could have decreased reflexes. And then we have the loss of higher brainstem function that can result in a persistent vegetative state. And the person does not purposely respond to any stimuli, is unaware of the environment, and has no cognitive or affective mental functions. So when we talk about the physiological stages of dying, this is something that is important for nurses to understand because families do not understand it. Families want their loved one to go from an active life to death. And this 1 to 3 months leading up to it is very difficult for people. So we usually say in 1 to 3 months prior to death, the dying person begins to withdraw from the world and people. Their sleep will increase. It becomes difficult for the body to digest food, especially meats. And their appetite and food intake decreases. Liquids are preferred. Anorexia may be present, and this can result in ketosis, which can diminish pain and increase the person's sense of well-being. It is very hard when a loved one enters this 1 to 3 month period and is not eating, and families might come in seeking guidance for G-tube insertions and things like that. 1 to 2 weeks prior to death, a host of physical changes indicate the body is beginning to lose its ability to maintain itself. Days to hours prior to death, often a surge of energy brings mental clarity and a desire to eat, talk with family members. However, as death approaches, patients tend to become dehydrated and have difficulty swallowing, which results in decreased blood volume. In the final hours of life, patients can become restless and agitated. This response may be caused by medications, liver failure, cerebral hypoxia, renal failure, stool impactions, distended bladder, increased pain, or unresolved emotional or spiritual issues. Near to the time of death, some people unexpectedly become coherent and energized for a time. Others become less communicative, quiet, and withdrawn. Fatigue is usually common. This period is when families can get very confused because they've already gone through the 1 to 3 months period where they're expecting it, and all of a sudden their loved one has a surge. And this is when they might say, okay, maybe we can, not do hospice anymore, not do palliative care. So it's really important that we have good education ourselves so that we're able to articulate what's normal to the families. And then moments prior to the death, the dying person does not respond to touch or sound and cannot be awakened. Typically, there's going to be a short series of long spaced breaths before breathing ceases and the heart stops beating. Your end of life care. Hospice and Palliative Nurses Associations promotes palliative sedation to manage unendurable and refractory symptoms. Palliative sedation is controlled and it's monitored, and the idea is to lower the patient's level of consciousness to the extent needed to achieve a relief of symptoms. Our palliative care is aggressively planned. It's holistic comfort care, and general issues for most end-of-life care patients include supporting the families and caregiver, ensuring continuity of care, ensuring respect for the person, informed decision-making, attending to emotional and spiritual concerns, supporting function and survival duration, and managing symptoms of pain, dyspnea, and depression. Palliative care has no timeline to it. Palliative care, your patients can still get certain treatments. So in palliative care, you might have radiation treatment to help with pain, to shrink tumors. You may still be giving them their blood pressure medication to support their normal function. And then we have hospice care. So hospice care is based on 2 key premises, and that's the quality of life is as important as the length of life. And those who are terminally ill should be allowed to face death with dignity and surrounded by comfort of their homes and family. Thus, hospice providers consider helping family members an essential part of their role. Hospice typically has a timeline. In both of these patients, your top priority nursing care is going to keep this patient comfortable. Our legal ethics and considerations. So we can talk about an advanced directives. These are a group of instructions stating a person's wishes regarding their health care if they were incapacitated or unable to make their decision. We have a DNR, your DNR, and then you can also have an allow a natural death, and then you can also have a do not intubate, and these are all regarding allowing natural death or DNR, do not resuscitate. These are, we're not going to do CPR, we're not going to do resuscitation methods. And then a DNI is a do not intubate, which means that if I start having respiratory distress prior to me stop breathing, you can put me on life support. So that's something that you would have to be familiar with your facility. Assisted suicide and euthanasia. These are not supported by the ANA. The ANA prohibits nurses' participation in assisted suicide and euthanasia because these acts are in a direct violation of nurses' ethical traditions and goals of the profession. and as it conveys to society. So nurses have an obligation to provide humane, comprehensive, and compassionate care that respects the rights of patients and upholds standards of the profession in presence of chronic, debilitating illness and at end of life. Euthanasia refers to deliberate ending of life of someone suffering from terminal or incurable illness. Active euthanasia occurs as a result of a direct action, so giving an overdose of meds. Passive euthanasia occurs as a result of a lack of action, so withholding medications or food necessary to sustain life. Again, the ANA does not support nurses to participate in assisted suicide or euthanasia. Autopsy is a medical examination of the body to determine the cause of death. Depending on your patient's religious and cultural affiliations, could depend on if the family allows an autopsy or not. However, there are certain laws that will trump the family from not wanting an autopsy. So we need to be aware of that. And that's something that I would suggest the physician has the conversation with, not the nurse. Your post. This is a physician ordered for life-sustaining treatments. This is a form written medical order from a physician, nurse practitioner, or physician assistant that helps give people with serious illness more control over their own care by specifying the types of medical treatment they want to receive during serious illness. The primary difference between a POLST and a DNR is that a POLST covers a variety of end-of-life treatments. It is a medical order, and a DNR only gives instructions about CPR. With a POLST, seniors can specify if they do or do not want CPR. So your nursing process, when we go through grief and loss, the first thing we're going to want to do is we're going to want to do our assessments. So what's your family's current knowledge base? What's your patient's knowledge base? Are they aware of what's going on? When the patient and the family are ready, we encourage them to talk. We want to know what their history of loss is, because we know if they've experienced loss before, they should have those coping abilities and those support systems in place. The meaning of the loss. How important is what is going on? If they're experiencing depression, grief, what's their physical assessment? And then we want to look at their cultural and spiritual assessments as well. So the diagnosis and nursing concepts for our terminally ill patients and families. We can look at loss and grieving as a problem. We can look at the dysfunctional or complicated grieving issues. We can look at loss and grieving as it occurs, if it creates a problem. We can have situational, we can have anxiety, we can have fear and anxiety, we can have decisional conflict, fatigue, spiritual distress, all of that stuff we could potentially use as our concepts. And then when we want to start to plan our outcomes, we want our patient, the overall big goal is that we want them to be able to cope, right? We want them to cope. We want them to process appropriately through the stages of grief. If they need to, we want grief resolution. They might need social support. We want them to express positive expectations about the future if that is appropriate. And then our interventions, so things that we can do for them is we can provide emotional support to the family as well as to the patient. We can encourage discussion of previous loss. We can include significant others in the discussions and the decisions as appropriate. For children, we can do therapeutic play. We can do active listening. We can do support groups. We can do crisis intervention, and we can do spiritual support. So remember, we're going to want to communicate with therapeutic communication. So you're going to want to perfect your listening skills. You want to make sure that you're not going to give a false reassurance. Don't say that everything's going to be okay, especially if we know that it's not. You want to increase your self-awareness. You want to encourage and accept the expression of feelings. Even if those feelings are anger, you want to let them get that out. We want to respond to nonverbal cues. We can with touch, with eye contact, and we want to continue to communicate even if your patient is in a coma. Don't think just because they're in a coma that they can't do it. So when we talk about facilitating grief, we want to encourage those feelings, like I just said. We want to encourage questions and respond to them with a reasonable time frame. We want to sit at the bedside, and we do not want to appear rushed, because if we appear rushed, they're not going to open up with us. We want to observe the family and the patient when we have people expressing feelings, either verbally or non-verbally. We want to encourage them to continue. We want to accept and expect a wide range of feelings. And again, this can be anger, fear, and loneliness. We can ask, how would you like me to help? What can I do for you? And we want to make sure that everyone on the healthcare team understands and follows the plan of care. We can recall memories with our families and our patient to kind of do that reminiscing, to encourage them to go through photo albums. We can find meaning, so facilitate life review is one technique to help the patient and the family recognize unique contributions that this person has made. And then bibliotherapy is a counseling technique used for grief therapy. It uses guided reading to increase awareness and understanding and promote healing. So poems, novels, essays, and self-help literature can help produce new insight, either as the patient retells the story or is guided to discuss their feelings and thoughts about the characters in the story. Helping families of the dying patient. So how can we do this, right? We want to encourage them to ask questions, encourage them to talk with chaplain. You want to provide anticipatory guidance. You want to acknowledge feelings of the families. We want to explore their coping mechanisms so that we can kind of guide them back to those former coping mechanisms. Remind them of other people, of the family members and significant others that can help take care of them. We want to teach what's expected and provide reassurance. We want to ask directly if the family wants to be present at the time of death, and at the moment of death, do not intrude. And do not intrude in other aspects too. If your family's praying, you do not need to interrupt their prayer circles to just become part of it. So in that thinking, doing, and caring model, we're here with a 55-year-old patient that was just informed that they have metastatic pancreatic cancer and has 4 months to live. After the provider leaves, she says to you, I don't want my family to know, but they have to know. Please don't tell them. Please tell me what to do. Help me. What's your best response, right? So if we're going to be the doing would be, I know this is difficult for you. Take time to think about it. This minimizes the situation and closes the communication. In essence, it's leaving the patient without providing support. This would not be an effective way to handle the anticipatory grief or loss. If we think it's D is caring. This is actually the best choice for this scenario. It's focusing and helping the client to express her feelings, provides insight into how to best care for this client. This choice should be combined with an effective act of caring, such as providing a hug or holding her hand as you allow the patient to talk, to express their feelings, or for them to be heard. If you were thinking the answer was B, B is similar to A. It does not address the patient's immediate needs and may also create a false hope scenario. In addition to disregarding the provider's information, it may create a barrier to reaching out to her family as a source of support. And then answer C uses words that may not be effective. Holding a person's hand may not make them feel better and implies a quick fix to the emotional situation. So care of the dying person, right? We need to meet their physiological needs. So those would be mobility, oxygenation, safety, nutrition, fluids, elimination, personal hygiene, and control of pain and symptoms. So some things that we might need to do for that, we might need to put a non-rebreather on a patient to help with oxygenation. We might need to perform oral care, oral hygiene, so that their mouth isn't dry. We might give them some Zofran to help with their nausea. We want to make sure that we're meeting these physiological needs. Meeting the psychological needs. Everyone involved with the patient should know exactly what the patient and the family have been told. Most patients want to know their prognosis as soon as possible so they can put personal affairs in orders, share their feelings with their family members, and come to terms with their life and death. That does not mean that you, the nurse, need to give them the results before the physician does. That's the physician's scope of practice. Addressing spiritual needs. The person may be looking for forgiveness or acceptance or reaching out to feel connected. Ways to address this need include empathetic listening, connecting pastoral care or clergy, and spiritual rituals, praying, music, meditation, and much more. If we're talking about addressing their cultural needs, some cultures may emphasize keeping emotions more subdued and limiting expressions of grief to a private setting, whereas others gauge the value of the deceased by the amount of crying. So we need to be aware. Providing post-mortem care. So this is care of the dead body. So post-mortem care includes care of the patient's body after death and fulfilling any legal obligations, such as arranging transportation to the morgue or to the coroner's office or funeral home. Key things that when we're providing post-mortem care that we need to remember is the laws that surround the death. So depending on the facility you work at would be whether you have to keep all the tubes and drains in the patient or whether it's okay to remove the tubes and drains. If we have somebody who dies in less than 24 hours of the hospital stay, somebody who dies after surgery, somebody that dies in restraints, somebody who has a questionable death, those things are all reasons why we might not be able to remove the tubes and drains. But if we are able to, we want to make sure that we remove that stuff before the family comes in the room to view the body, so that it's less traumatic, and they can view the family member more as how they remember them rather than all the medical stuff around them. We also have to be aware of their belongings. You have to remove belongings. And if you remove things like wedding bands, watches, make sure that you hand those to the appropriate family member and then also document who you handed them to. Very often, certain sentimental mementos go missing, and they can come back to the hospital staff looking for them. So it's just important to cover yourself and ensure that. Helping family members, right? Again, we want to provide grief education. The grieving person may be fatigued from not sleeping, they may be disoriented or unable to concentrate, and so on. They may be concerned about what symptoms mean. We need to reassure the person that responses that are going on are expected, that there's no right or wrong way to grieve. And then helping children deal with loss. Some families may need information about helping children deal with grief. I use the example in class. Children do not necessarily understand that the loss of a parent is forever, and you may have a grieving parent who's very upset, and then they'll become increasingly upset and frustrated when every day the child asks, well, when's mommy coming home? So it's really important to help children and families of children deal with that loss. The loss of a patient, right? You as the nurse are experiencing a loss as well. It's normal for the nurse to feel grief when a client dies. We need to make sure that we care for ourselves, and we need to make sure that we don't mask that loss with improper grieving of substance abuse and alcohol abuse. And that is the end of that lecture.